Anesthesia webinar series planned by the Obstetric Committee of College of Anesthesiologists and Intensivists of Sri Lanka. The Obstetric Committee has decided to conduct this webinar every month on the third Wednesday. So please keep that time slot free in your calendar. Without taking up much of your valuable time, let me introduce our moderator for the day, Dr. Iresha Walavage, consultant anesthetist at Castle Street Hospital for Women. She is the chair of the obstetric committee of the college. May I now invite her to introduce our speaker today, Dr. Sunetra Ratnasiri, and outline the housekeeping rules and conduct the webinar. Thank you. Have a pleasant evening.
Good evening, everybody. Our aim is in this series of lectures is to uplift anesthetic care of the obstetric patients in the country. So please join every month. We are going to have a series of lectures. This is going to be the first lecture of this series, and it's going to be done by Dr. Sunetra Ratnasiri. She is the senior consultant anesthetist at Disoisa Hospital for Women in Colombo, and she has experience in managing a lot of complicated maternal patients, and so she will be doing this principles of obstetric anesthesia and maternal changes and their impact on the anesthetic management. Then over to you, Sunetra, so you can start the lecture.
Okay, thank you, Dr. Resha, for your kind introduction. And it's my pleasure to deliver the first lecture of this series. And I'm very much thankful to the Obstetric Committee and the College of Anesthetists for giving me this opportunity. So my topic is principles of obstetric anesthesia, maternal changes, and its implications on its anesthetic implications. So first of all, I'm going to just give a brief introduction. So as we all have experienced, the obstetric anesthesia is a challenging, it's difficult, and it's high-risk practice, which exposes the anesthetist to increased medical legal liabilities. And our main goal is to ensure safe, specialized management of maternal and fetal well-being to finally have the happy outcome. So obstetric anesthesia is not only focused on providing anesthesia for C-sections, but also involved in pain relief during labor, anesthesia for postpartum procedures, being a rapid responder to obstetric emergencies like maternal collapse, severe PPH, etc. And sometimes providing anesthesia in early pregnancy for obstetric and non-obstetric procedures, being a crucial member in the MDT multidisciplinary team in the management of high-risk pregnancies and providing intensive care for these high-risk mothers. So our main aim is safety priority. So it requires to achieve that. It requires a comprehensive multi-layered approach through understanding of key anatomical and physiological changes occurring in the pregnancy, mastering core techniques and procedures and skills, effective management of the airway, which is an essential skill for obstetric anesthetists, specialized training, spinal epidurals and CSE, combined spinal epidurals, effective management of failed, inadequate, spinal epidural blocks, and being a crucial member of the MDT with close collaboration with obstetricians, midwives, nursing staff, and other relevant medical specialties, and resource management, adapting protocols and guidelines for tertiary care hospitals and limited resource settings. So moving on to the maternal anatomical and physiological changes. These occur secondary to the effects of progesterone and estrogen, begin as early as 4 weeks of gestation, and they are progressive with the pregnancy. In the first 12 weeks within the first 12 weeks, these hormones are secreted predominantly from the ovaries and thereafter by the growing placenta to meet the metabolic demands of the growing fetus and to prepare the mother for labor and delivery. So due to the increased metabolic demands of pregnancy, so oxygen consumption progressively increases by 20 to 30% at term and more than 60% during labor. So due to reduced oxygen reserves, because of the cephalid movement of the diaphragm by the gravid uterus, pregnant mothers are more prone to rapid oxygen desaturation during periods of apnea or obstruction of the air. So basically, our functional residual capacity reduces by 20 to 30%. Expiratory reserve volumes drops by 25%, and residual volumes drop by 15%. So all the maternal oxygen reserves are reduced. Furthermore, the anatomical changes of the upper airway makes it difficult. So difficult intubation is 8 to 10 times higher compared to non-pregnant. So capillary engorgement and edema promotes trauma, bleeding, and obstruction to the upper airway. Difficult laryngoscopy due to enlarged breast may take longer time for intubation. Therefore, pre-oxygenation 100% oxygen for 3 to 5 minutes by the clock is vital before induction of GE. And also the gentle laryngoscopy, use of smaller size ET tubes minimizes airway trauma. The progesterone action on the respiratory center increases the sensitivity to carbon dioxide, thereby increase the minute ventilation, and despite the increased production of carbon dioxide in pregnancy, creates respiratory alkalosis. And during anesthesia, excessive hyperventilation may cause the left shift of the maternal oxygen dissociation curve, causing fetal acidosis by lowering the oxygen delivery to the fetus. So therefore, it is vital to maintain arterial carbon dioxide tensions at lower normal range for pregnancy during mechanical ventilation. And also due to the increased minute ventilation, it accelerates the uptake of volatile anesthetics, and therefore it hastens the inhalational induction. So moving on to the cardiovascular system. The progesterone action on vascular smooth muscle causes relaxation of the smooth muscle, causing reduction in systemic vascular resistance. This occurs as early as 8 weeks of gestation, causing reduction in systolic blood pressure and diastolic blood pressure. So as you know, arterial pressure is the product of cardiac output into systemic vascular resistance. So therefore, to maintain arterial pressure, so as the SVR is reduced, the cardiac output need to be increased. So initially it is achieved by increased stroke volume. Later, as the pregnancy progresses, by the increase in heart rate. So you can see in this graph, initially the red line is the stroke volume. Initially stroke volume increases, but the heart rate remains same. But later in the pregnancy, both curves get together. So the increase in stroke volume is mainly due to preload and increased end-diastolic volume by the increased blood volume during pregnancy. So the blood volume increase starts as early as 6 to 8 weeks of gestation and is progressive and to a maximum volume at 32 weeks. So overall increase up to 2000 ml or 2 ml compared to the non-pregnant. So therefore, pregnant mothers will compensate for blood loss. So as you see in this box, so more than 2 liters loss will only cause increase change in cardiovascular parameters. So that means up to blood loss of 1500 ml can occur without any change in cardiovascular parameters, so may go unnoticed. Cardiac output further increases during labor and delivery. During the delivery, secondary to the transfusion of uteroplacental blood flow into maternal circulation. So the preload and the afterload of the heart changes rapidly during this time. Therefore, women with impaired cardiac function are at greatest risk at this time. Average blood loss during normal vaginal delivery is 400 to 500 ml. And during C-section, about 800 to 1000 ml. So more exceeding these levels, we consider as postpartum hemorrhage. So the blood volume returns to normal after 2 weeks postpartum. So despite an increased cardiac output, early transient decrease in arterial pressure causes widened pulse pressure, which activates the renin-angiotensin system, causing retention of sodium and water, which causes increase in plasma volume, in other words, the blood volume. So this increase in plasma volume is by 40 to 50%, but the red cell mass is only 20%. So therefore, it results in physiological anemia of pregnancy. Other important phenomena is aortocaval compression and supine hypertension syndrome, which is significant after 20 weeks of gestation when the uterus reaches the level of L4, L5 interspace. When the gravid uterus rests on the aorta and inferior vena cava, when the mother is in supine position, it causes pressure over these structures, blocking the venous return to the heart, causing reduced cardiac output and maternal hypertension, It may even be severe enough to make the mother unconscious. Compromising uteroplacental blood flow, which is not autoregulated. So therefore, it is very important to keep these mothers left lateral in the theater while they are waiting for the C-sections. Or when you need to adopt supine position, like in cardiac arrest during CPR, you have to keep a wedge under the right hip to unload the gravid uterus from these structures. So you can see that in this picture, if you can see it. So moving on to hematological changes. So pregnancy is considered hyperpermeable state to facilitate clotting at the time of placental separation to prevent bleeding during delivery. Therefore, there is tenfold higher risk of venous thromboembolism and even more risk at the postpartum period. All clotting factors except factor 11 and 13 are increased. The natural anticoagulants are reduced. The fibrinolytic activity is reduced mainly during late pregnancy. Therefore, routine thromboembolic risk assessment for all mothers antenatally and prescription of appropriate thromboprophylaxis is essential. So at the same time, aware of the time of the last dose of enoxaparin before your regional blocks. Sometimes we missed the time and we give the spinal and we have to face the consequences. Regarding the platelet production is increased, but due to the increased destruction and the hemodilution of the raised plasma volume, so it is seen as low count. So that is called thrombocytopenia in pregnancy. So it is considered when it is lower than 150,000. So when you see a patient with low platelet count, you have to exclude other causes, especially the severe PIH, HELLP syndrome, acute fatty liver of pregnancy. So in severe PIH, platelets drop rapidly. Therefore, recent count with the 6 hours needed before our regional anesthesia. Considering the leukocyte count, it is normally elevated up to 14,000, but may increase further after, during labor and delivery. So it is not indicative of evolving sepsis, but the cell-mediated, as we all know, the cell-mediated immunity is markedly depressed. Therefore, these mothers are highly prone to sepsis. So we need to keep eye-opening in these mothers. So moving on to the GI tract, which is more relevant, more considered we as anesthetists, because these pregnant mothers are considered always full stomach because of the upward and anterior displacement of the stomach by the gravid uterus causes mechanical incompetence of the lower gastroesophageal sphincter, and it increases intergastric pressure, and plus the progesterone effect on the lower gastroesophageal sphincter, it reduces the tone. So the hypersecretion of gastric acid from the placental, from the gastrine, due to the gastrine secreted from the placenta, makes the gastric secretions more acidic. So therefore, these mothers are at high risk of aspiration of the gastric content, which is very acidic, leading to Mendelssohn syndrome. But now it is rare because we admit most of the time the regional anesthesia for these mothers. So therefore, aspiration prophylaxis is recommended for all mothers over 16 weeks of POA. So we use histamine receptor antagonist, sodium citrate, as the drugs. And rapid sequence induction with cricoid pressure, cuffed ET tube, will minimize the risk. But the safest mode of aspiration prophylaxis is effective use of regional anesthesia. Moving on to hepatic changes, the standard liver function test, the serum albumin transaminases and serum bilirubin levels generally lower than the non-pregnant state. But the serum alkaline phosphatase may be elevated due to the placental production. So the plasma and the plasma cholinesterase activity is reduced from 10 weeks onwards to a maximum in the third postpartum day. So this is decreased by 33% compared to non-pregnant due to the hemodilution effect and reduced synthesis from the liver. But you need to have 50% reduction of the plasma cholinesterase activity to have the increased sensitivity to succinylcholine. Therefore, no dose adjustment required. Endocrine changes. So most common and most important, the change is this. It makes the mothers diabetogenic due to relative insulin resistance, despite compensatory increase in synthesis and secretion by beta cells of the Langerhans islets. The fetal insulin levels are independent of maternal production, but it depends on maternal glucose load. So therefore, poor maternal glucose control will lead to fetal macrosomia and neonatal hypoglycemia after delivery. So moving on to the renal changes. The renal blood flow increases by 50%, and the glomerular filtration rate increases by 100 to 150 ml per minute by the second trimester, leading high clearance of urea, creatinine, and some drugs. The serum urea and serum creatinine levels usually maintains at lower level comparing to non-pregnant, about 40% reduction. And the GFR, the rise in GFR overrides the capacity of reabsorption in the distal convoluted tubule. So therefore, urine, glucose and proteins appear in the urine. Due to the action of increased action of aldosterone, there is sodium and water retention, leading to elevated volume of distribution and increased elimination half-life of certain drugs. So the renal impairment commonly seen in severe PIH patients that need to be careful on the fluid management and adjustment of drug doses and regimes. The central nervous system changes. as I previously mentioned, due to the pressure on the distal part of the aorta and the inferior vena cava, the increased venous pressure below the gravity uterus diverts blood flow through the least receptor pathways, leading to divert blood through the epidural venous plexuses and causing engorgement. That results in reduced potential volume of the epidural space, which increase epidural space pressure, and there will be compensated reduction of CSF volume within the subarachnoid space. So, on the other hand, there is hypersensitivity to local anesthetics due to the hormonal effects on the neurons. And also the higher apical level of the thoracic hypophysis, there's a tendency of these local anesthetics to move carefully, causing high spinal and epidural blocks. So therefore, the local anesthetic dose requirement is reduced and need to be reduced by about 25% compared to non-pregnant to avoid high spinals and high epidural blocks. And also because of the hypersensitivity, there will be more rapid onset and longer duration of action of these blocks comparing to the non-pregnant. So minimal alveolar concentration values for volatile anesthetics progressively decrease throughout the pregnancy. Maximum reduction seen at the term by 30 to 40%, all because of the hormonal effects on the central nervous system. Therefore, use less volatile anesthetics, and these volatile anesthetics have relaxing effect on the uterine smooth muscle, and there's a liability of uterine atony and resulting PPH. So finally, it reaches the end of my presentation. So the key principles, key considerations of obstetric anesthesia, we need to emphasize is a full stomach. We have to consider all mothers over 16 weeks of POA as full stomach up to the 48 hours postpartum day. So therefore, aspiration prophylaxis is mandatory in these mothers. And also hypoxemia during period of apnea or obstruction to airway. So that we need to be kept in our mind, and therefore pre-oxygenation is mandatory. So the incidence of difficult intubation is 10 times higher, which is compared to non-pregnant mothers. Therefore, this increased safe period of apnea is very much important at induction. So blood loss more than 1.5 liters can occur unnoticed without any changes in cardiovascular parameters. So we have to be careful because we might see the mother is stable, but she has lost 1,500 liters of blood. And avoid aortocaval compression in every mother's. And it can occur without any symptoms, causing fetal acidosis. So key considerations in our basic principles are cricoid pressure and cupped endotracheal intubation, acid aspiration prophylaxis, pre-oxygenation, left lateral tilt, effective use of regional anesthesia, and plus the 5 R's for maternal safety. It is readiness, that is preparation of the environment, maybe the theater, maybe the ward, and the mother. Secondly, to recognize, that is to early identify the deteriorating mothers, warning signs using consistent protocol. Thirdly, to respond early to prompt and standardized action to address complications. Fourthly, to reassess continuous evaluation of the effectiveness of the response. Finally, the reporting and system learning, analyzing cases, auditing systems to improve care and learn from outcomes. So these are the key considerations, key principles we have to follow to provide safe anesthesia for pregnant mothers as obstetric anesthesia. So that concludes my lecture. So thank you, everybody.
And one more thing I want to add to this lecture about pre-oxygenation. When you pre-oxygenate, Dr. Sunetra said to pre-oxygenate about 3 to 5 minutes. And you please check the enteral oxygen concentration till it is more than 95%. I think you should pre-oxygenate. And the other thing, during COVID season, most of the hospitals got high flow nasal oxygen, and you can use that to pre-oxygenate, and you can use it during, even at the time of intubation, you can use high flow nasal oxygen if it is available. And the other thing is, if you have video laryngoscope in your institution, now it is recommend that it is the first line instrument to use for intubation, not the conventional laryngoscopy. It is recommended to use video laryngoscopy as a first attempt for obstetric patients, because it's known to be a difficult intubation anyway when compared to the other patient. So, and the other most important thing, call for senior help early. That's the most important thing. And if you are planning to give GA, maybe spinal has failed, or if it is a contraindication, so before giving GA, you have to inform the seniors that you are going to give GA, and then you get their opinion as well. Thank you very much, Sunetra, for delivering this lecture, and Chamila for organizing it. And thank you, everybody.